This week on the Back Table Podcast.
Performance status is always key, right? Like anything I do is not going to make it better per se, right? At least in the short term, right? And so if they have very limited performance status at baseline because of their tumor disease, it's going to be hard for me to make that better with an aggressive local therapy. So in that scenario, I might recommend systemic therapy. And we can always consolidate if there's, if their performance status improves as they get tumor shrinkage.
I think that depends on why their performance status is poor, right?
Yeah, that's
like,
good.
Are
That's
you
a good
tired?
point.
Are you constantly throwing up because of tumor burden, because of HCC, like pretty extensive? Then hopefully once I start you on treatment, you magically feel better. Or if it's like you're chronically with so many comorbidities, you're just not a healthy person, then if you're weak at baseline, not because of the cancer, then my treatments likely make you even weaker.
But I will say, I know as medical oncologists, it is around the country. You have your clinic days, you have outpatient, visits. Not all IRs do. And I think this is a big plug-in for if you're going to really be doing oncology and interventional oncology, you really should be seeing these patients in a clinic setting. You should be meeting them. Because a lot of performance status comes from, talking to the patient and or their caregivers. And I think that's a very, very important thing if you're going to be doing these therapies.
Yeah, you get that gestalt when you meet the patient,
It's a clinical call.
Is this person going to tolerate so much therapy and all that?
Welcome to Back Table Tumor Board, your source for the latest on multidisciplinary cancer care.
All right, well, welcome everyone to Creators Weekend. It's really nice meeting a lot of you. Let's start off with some introductions from the right side of the table for today.
Sure. My name's Adam Burgoyne. I'm a medical oncologist at UC San Diego.
My name's Lingling. I'm a GI medical oncologist at Ochsner in New Orleans.
I'm Kirema Garcia-Reyes. I'm an interventional radiologist in New York at Sinai.
And I'm Zach Berman. I'm an interventional radiologist here at UCSD.
Great. And I'm Sabeen Dhand as your host. And basically, we're going to be delving into this complex scenario, the gray zone of treating patients with HCC. I kind of wanted to bring up, BCLC, a little bit of a review of the updated 22 guidelines. Who wants to kind of just touch base on that?
Sure. So the BCLC guidelines are very unique in the fact that they not only incorporate tumor size and multiplicity, but also performance status of the patient, which is very important for our patients who have HCC because they are both battling cancer, but also chronic liver disease too. And so you have to keep that in mind. So on the very far left-hand side of BCLC, you have early stage disease, and we're looking at curative intent therapies, which means we want a survival of 5 years at least on average. Then you get to the far right of it, we're talking about more advanced patients, patients with impaired performance status or metastatic disease or tumor vascular invasion. And then those patients, the survival is considerably less than 5 years. And then you have the middle, which is BCLC-B, which is where we spend most of our time today talking, but it's everyone in between, where maybe we're going for curative intents, maybe we're going for more palliative intents. We don't really know. What I love about it is that if you look at the right side of BCLC, it's huge with like 15 different treatment options. If you look at the very left side of BCLC, there's like 15 different treatment options. But the most complex, at least in my opinion, we'll probably argue today, is BCLC-B in that middle. It's a tiny little column, but man, there's so much debate with what to do.
It's a tiny column, and I think a lot of us deviate from just exactly what the column suggests. So, how does performance status play into your role of patients who have good liver function? What in the BCLB status, what are you offering these patients? Burgoyne?
I think it depends. Obviously, liver function, performance status, tumor burden is important. But, as you alluded to, the sliver in the schematic is small, but the heterogeneity of the patient population is huge. And we want to make sure that whatever we're delivering is safe, but also what's going to deliver the highest amount of efficacy for that patient.
Yeah, and we discussed, we were having a discussion before about ECOG performance of 1, and that pushes you to far to the right of the table. How many, Kirema, how many patients that are you treating that are ECOG 1 and 2 under liver-directed therapy?
So I would say, just going a little bit back to the BCLC 2022 update, there was two big things I think that changed that were really important. One of them obviously being, BCLCC, including all these systemic therapies after the landmark trials. And then, on the BCLC and you were saying how we kind of practice a little bit outside those guidelines, but radioembolization finally got on the map. So I think those were two really important things that we saw in 2022. But when we're talking about this intermediate stage and also the advanced stage, but there's a lot of heterogeneity in these groups. And I think, so it's not the same. And same with advanced disease, right? So when you're asking me about an ECOG-1, it's not the same treating an ECOG-1 patient with preserved liver function and a small tumor than treating a patient with portal vein invasion. So I think, I would say most of my patient population still has a pretty good performance status. Usually I'm not doing local regional therapies on patients with an ECOG of 2, ECOG with few exceptions, and then ECOG-1, little obviously more than ECOG-2, but usually patients where I think, the reason we think about this is because we want them to tolerate this therapy, right? We're trying to, even if palliative, we want their quality of life. We don't want to make them worse. So I tread really lightly when I'm choosing these ECOG-1 patients, and it's usually like radiation segmentectomies or straightforward ablations where I know I really won't affect their liver function.
Okay.
Just back to your question of like the performance status. I think being medical oncologists, we're so used to seeing more advanced, sicker patients. So the ECOG, like in my personal opinion, ECOG-1 is terrific. ECOG-2 is I can treat you. ECOG-3, ECOG-4, then like you come in a wheelchair, then no, I don't really think systemic therapy is appropriate. But ECOG-0 through 2, I don't think that really make me feel that, I cannot offer you systemic therapy. And when it comes to performance status and liver function, I do feel that it's more common for patients with poor liver function that have poor performance status rather than, their liver function is great, but the performance status is poor. That's not really our typical HCC population. I do feel that they have usually have poor performance status because when their liver function got so bad.
And then, so in our institution, and I'd be interested in hearing how you do it. So usually an ECOG-2 patient is a patient that we will start with systemic therapy before, offering any of our local regional therapies. How are you guys doing it at USCSD?
Well, it's entirely patient-specific, right? So let's say they are ECOG-1, ECOG-2, and they have only a solitary tumor, right? You're a little bit more inclined to do local regional therapy. What if they have borderline 3 tumors that you could probably treat with local regional therapy, but you're kind of pushing it? Then I think it makes sense to go more systemic. And so I don't think just having a blanket, they're ECOG-1, ECOG-2, we can't offer local regional therapy. But for someone who's ECOG-0, I might be more aggressive with. You obviously do pull, the brakes on a little bit.
And I think that's a great point, and that's why, we have medical oncologists and us in this conversation. It's really a multidisciplinary effort, and each case is personalized, and it's worth discussing on its own. So
I think a lot of times it's really not the performance status, as long as it's not like 3 and 4. A lot of times it's the liver function that make me decide whether I want to do everything at the same time or I literally just want to start with systemic therapy and see how their liver function continue to progress and decide on the next step.
Zach, you mentioned before about the ALBI score and, liver function. A lot of us think of LFTs, bilirubin, and et cetera, but can you talk a little bit about the ALBI score?
The concept of albumin is super important, right? And so I think it's undervalued. So it's in child's pew, right? So you theoretically have a low albumin and have a high child's pew, and I think that's important. But people can have completely normal bilirubins with an albumin in the 2s, and for anything we offer is going to tip. They're like barely hanging on, right? And so it's going to definitely tip it over the edge. And so the ALBI score, which is some complex mathematical equation of it, is able to kind of combine all of that into, a nice package that I can interpret and how to do it. So even if their bilirubin is less than 2, which is the technical on-label used for most of our therapies, if their albumin is super low, they're still not going to tolerate it. And so the more I've done this, the more I've included albumin in my assessment of these patients.
Is that the same for systemic therapies too?
I actually go by Child-Pugh score.
Yeah, we primarily are in the Stone Age using Child-Pugh still, but I think the difference too is that the treatments that you are all offering in the local regional space are directly affecting the liver parenchyma. You're worried about sort of direct toxicity, and with the advent of immunotherapy and largely monoclonal antibodies that we're using, we're not worried about metabolism of drugs and our drugs unless there's like an immune-related adverse event in the liver causing direct toxicity to the liver. So as long as we feel like someone's liver function is in a safe enough zone for them to receive immunotherapy, we're, I think, less concerned about that from a downstream effect of the treatment we're giving.
Got it. Now, immunotherapy on the BCLC is in the C stage. They have a very nice table for that. Are you offering immunotherapy to patients in, the B, A or B stage?
I think on the 2022 BCLC staging, immunotherapy is recommended for patients with BCLC stage C, but also B with like the very right B, like the late B, like diffuse bilobar disease, that they recommend the line is straight down to systemic therapy alone. I do feel that in practice, we actually treat way much more patient than only the C and B. I think even the B, even if it's not like bilobar, if it's large tumor burden, as long as large tumor burden, a lot of time our IR colleagues feel that like my local region therapy is not able to control everything, then they send the patient to us.
Yeah. Do you guys see that too?
I think in our group, we are using it. So it's this concept of high risk features, right? That a lot of people define differently, but patients who, these infiltrative HCCs, kind of at the right of BCLCB, that are the ones you're talking about, definitely. But also, these patients that have high tumor burden or maybe like intermediate, but then their AFP is off the charts, right? So this patient, sometimes we may do local regional and, we get it a lot lower, but these patients, there are cutoffs, right, for transplant. So if we're trying to downstage these patients, so we tend to think part of it, again, case by case and a little bit of a gestalt, right? So this tumor looks ugly or this AFP is really high, or so we tend to incorporate immunotherapy in those cases.
Yeah.
I think too, we have to think about our goals for these patients. And like, to your point, a lot of that does come from gestalt, but do you think this person is more on the right side, that this is palliative therapy? We are looking to hopefully prolong knife control symptoms, or is this someone that with an aggressive multimodality approach, can we get them to the leftward shift? Can we think about curative intent? Can we think about downstaging? And we're not great predictors of that, but I think those are the things that we think about when we're trying to make these decisions.
Where is that line then between your curative and palliative? Like what patient do you see who is, in that B to C stage that you say, okay, let's go for a curative intent rather than the palliative? What are some features?
I mean, no extrahepatic spread, hopefully limited to no amount of tumor in vein. So people that have intrahepatic disease that hopefully are lower tumor burden, that you feel like you could potentially get to be within transplant criteria. And
I think another thing that comes to mind is this concept of tumor biology, right? Just not what we're seeing in one point, but how has the disease evolved, right? So if this is a patient, intermediate stage, multifocal tumors, we do local regional therapy, and then they show up 3 months later with a lot of new tumor, or just then, we modify our approach. So I think that concept of tumor biology and not all tumor is the same is very important.
And then speaking of extrahepatic disease, does it change if you have some local extrahepatic disease, some lymph nodes that are a bit enlarged in the portahepatic area versus something, more distant, lung nodule? Does your treatment regimen change based off of that?
Metastasis outside of the liver is by definition a systemic disease, so it should be treated with systemic therapy. Now, that being said, as we were talking on the way over here, with systemic therapies, we can still offer local regional therapy on top of that, but the backbone of therapy has to be systemic.
Okay, but let's go into that more, because again, this is where we're deviating from BCLC, and we're offering systemic as a backbone and then a local. So is this something that you consider in all patients who have extrahepatic disease? Is it based on their performance status? What are the variables that are coming in that are getting you to do both therapies at once?
Of course, basically all our patients who we will likely offer both, like combination therapy, both local regional and systemic therapy, they need to have good performance status and adequate liver function, right? For patients with metastatic disease, usually we will offer them combination therapy if it's oligometastatic disease, like just one or like very few spots outside the liver. If it's widely metastatic disease, then we usually don't do a 190.
Is that similar?
Yeah. Also, if they have metastatic disease, that means the disease is aggressive enough to leave the liver, right? It's developed enough mutations to escape the local control inside of the liver. I personally don't like to just run straight to local regional therapy because there are toxicities with what we do. And if they're just going to continue to progress even on immunotherapy, my little whatever I did in the liver is not going to help the situation, right? I personally like to see initiation of systemic therapy with response, or at least disease stability, before we start adding it, because then they're going to derive likely a clinical benefit because they're not going to die of the metastatic disease, or less likely to, more likely to die of local progression inside the liver decompensation. Then you can make the argument that a local therapy to the primary tumor site makes sense.
And what's an appropriate time interval for a response? Is 3 months really the time that you're using to see a response from systemic therapy, or longer?
Typically, we would think longer. Immunotherapy has sort of unpredictable timelines. And for those folks that are responding to, we want to see where that response is heading. I mean, what if we're going to head towards a CR? With immunotherapy alone, we don't need to rush in with a local approach if someone's doing really well.
So what about, I've had a couple instances where I've had a synchronous tumor in a patient, a colon cancer, and then there's an HCC. How do you approach that type of patient?
I actually do have a patient who needs FOLFOX for colon cancer and also like BCLC stage C, portal vein invasion from HCC. We actually that year at ASCO, we had, I think, an oral presentation that they did tested FOLFOX plus atezo plus bev. So in colon cancer patient, however, we did use that FOLFOX plus atezo-bev. It's just like atezo-bev is a little bit, I think, every 2 weeks dosing.
And I know this is not data-driven, but is there a role for a liver-directed therapy in those type of patients?
Sure. And also no.
Yeah.
It really depends, right? So it also depends whether they have cirrhosis or not, right? So if this is a Hep B person who develops this, you can be a little bit more aggressive. And you guys can also feel more aggressive with atezo, bev, FOLFOX. But if they're cirrhotic, is the treatment going to be worse than the disease at that point, right? Like if we just do chemo immunotherapy plus targeted therapy plus local regional therapy, is that too much, right? Because they still have presumptively a primary disease at that point too, right? The colon cancer inside the colon that you're not treating other than systemic therapy.
I think this is, again, deviating a little bit, but when we're thinking about, when we're at least local regional therapies, when these are very different patients, right? When you're treating HCC in a patient with cirrhosis, you're treating the HCC, but you're also, you're managing the underlying liver function. When you have a patient with metastatic disease, these are two synchronous, but with metastatic disease to the liver, it's different. It's a different patient substrate. This is a systemic disease. These are patients that might come from lines of chemotherapy or might need systemic therapy afterwards. So I really do, when I'm treating these patients, I really do think about them differently.
Okay.
Right. And I do feel that, like, just in general, cirrhotic patient, if they develop cancer that needs cytotoxic chemotherapy, it's hard because a lot of times because of platelet counts. A lot of them, like, platelet counts are too low. We cannot even introduce cytotoxic chemo.
The most common synchronous tumor I've seen actually is concomitant cholangiocarcinoma. Okay. So patients who get both cholangio and HCC or mixed tumors, which can always be tricky. Luckily now immunotherapy is part of the cholangio guidelines, right? So,
but also with the chemo backbone.
Right.
Yeah. So their platelet count cannot be too low.
So you're offering both liver-directed therapy and systemic in those mixed tumor.
It just depends, right? So if they have a huge cholangio and HCC, maybe we're like, let's see how systemic therapy goes. But we've shared some patients, they have like a tiny cholangio and a tiny HCC, and they're cirrhotic. Maybe you guys aren't crazy about giving cytotoxic chemotherapy to that person. If we can treat locally at both and kind of kick the can down the road as long as we can, that might be a beneficial route.
Okay. Some other situations. So a patient who gets treatment, whether it's systemic or liver-directed therapy, and their performance status significantly decreases, as a side effect from the therapy, and you have a partial response. What do you just cut therapy at that point, or what are your options?
A lot of times it's not really the performance status. I would say the liver function deterioration precedes performance status deterioration. So usually it's actually the liver function make me tell the patient that, hey, the liver function today is not good. We're going to hold the systemic therapy and wait to see if it recovers.
Have you had any patients where you've treated and they've gone down to performance status?
I've never had a single complication.
Yeah, that's right. Of course.
No, I think it can get complex, right? The patient who was maybe a Child-Pugh 7, right? And even though you did a radiation segmentectomy, most of these patients do well, but every so often there's the patient, and then they develop ascites, right? So what do you do? Sometimes they do come back from that and all they need is, a little bit of a tune-up, sometime in a tune-up with their hepatologist and get a little bit of diuretics, but those situations happen. I think something that's really important, again, I keep talking about not just one point in time, but how things are kind of moving along is, when we're I've seen some patients, and I'm sure Zach as well, that from the time of mapping, from the time when we see them in office hours, and then we have our plan to do radioembolization, and then they come for the mapping, and then the Billy went from 1 to 1.7, or there was no ascites, and I'm seeing ascites on my cone beam. So those are the moments where you kind of really have to stop, and we all kind of gather around, try to figure out, if is it something that just acutely happened to decompensate this patient, or is this patient somebody we should hold off on?
I think that's a great point. Even in the systemic therapy space, and a lot of protocols are now incorporating like a day-7 labs so that we catch those patients that are rapidly deteriorating so that we don't offer therapy to someone that's rapidly decompensating. But in the immunotherapy era, it's fairly uncommon that patient deterioration is from our treatment. Of course, it has some toxicity, but the majority of the time it's due to clinical progression or worsening liver disease. And then that discussion is really, do we move forward with next line therapy to try to get better tumor control and hope that's going to get better? Or are we starting to head towards a terminal decline and we're really thinking more about palliative interventions?
Yeah. Some other kind of situations that I'm thinking about are, I've touched base on performance status. Now, performance status in a larger tumor, we kind of touched base on that earlier. Is that something where you consider systemic therapy more versus liver-directed therapy, or a combo of both?
Performance status is always key, right? Anything I do is not going to make it better per se, right? At least in the short term, right? And so if they have very limited performance status at baseline because of their tumor disease, it's going to be hard for me to make that better with an aggressive local therapy. So in that scenario, I might recommend systemic therapy. And we can always consolidate if there's, if their performance status improves as they get tumor shrinkage.
I think that depends on why their performance status is poor,
Yeah,
right?
that's
Like,
good.
are you
That's a good point.
tired? Are you constantly throwing up because of tumor burden, because of HCC, like pretty extensive? Then hopefully once I start you on treatment, you magically feel better. Or if it's like you're chronically with so many comorbidities, you're just not a healthy person, then if you're weak at baseline, not because of the cancer, then my treatments likely make you even weaker.
But I will say, I know as medical oncologists, it is around the country. You have your clinic days, you have outpatient, visits. Not all IRs do. And I think this is a big plug-in for if you're going to really be doing oncology and interventional oncology, you really should be seeing these patients in a clinic setting. You should be meeting them. That's you, because a lot of performance status comes from, talking to the patient and see, or their caregivers. And I think that's a very, very important thing if you're going to be doing these therapies.
Yeah, you get that gestalt when you meet the patient.
It's a clinical call.
Is this person going to tolerate so much therapy and all that?
To follow up on that point, when possible, this is when multidisciplinary clinics are so helpful. So if Zach and I are in clinic together and I can describe someone's performance status, but if you walk in the room and see the patient, it's eye-opening sometimes to get a sense of how am I heading taking care of this person? And also it provides for real-time care.
We have the same model. We do multidisciplinary. I share medical oncology, hepatology, as well as liver surgery. And I realize this is not work. Not everybody has the infrastructure for this, but this is really the ideal way to take care of these patients.
What do you suggest for people like me in the community who don't have access to a whole clinic with multidisciplinary care? How can someone like me get the input of everyone for a complex patient?
I think, first of all, having, again, the clinic, right? Seeing patients. I think even if it's not same day, there's ways to create tumor boards and discuss and just being in constant communication with the rest of the team for the patient, I think is going to be really important, which I understand, at our institutions, we have weekly tumor boards where every patient who comes in is discussed. But obviously it's a little trickier, but it still happens in the private practice world.
Yeah, we communicate, via phone and phone calls and stuff, but it's just, it is really nice to have one little area to see the patient and bounce the patient back, which again, in the communities, we just don't have.
I think it is a gap too. And I think we've learned a lot in the post-pandemic era, how to incorporate telehealth and virtual interactions into our practices. And I do think that there are opportunities for virtual connections, virtual tumor boards, ways to connect folks in the community together that don't have access to those academic multidisciplinary clinics, because it is really helpful to have that real-time dialogue.
And then what about a patient who kind of shops around? So let's call that as a complex patient. You see the patient and you offer systemic therapy, but they're online looking at their own data and they want liver-directed therapy or histodrypsy. How do you navigate that patient and what would you suggest?
Usually if patients is just like want, say, Y90, it's no problem. That's like if we feel that the patient will benefit from combination, we refer them to like Juan and I and Tyler, we talk almost every day. When it comes to other, like say the patient had 30 tumors in the liver and they want histotrypsy to one of them. To be honest with you, I do feel that ours are good resources that they are actually they are able to talk to the patient about the nuances between different procedures. Like, why am I offering you this but not that one?
So there's patient autonomy, right? The patients can request anything they want and they at least have a right to get more information about it. And most of the time, you can have them meet with a provider. You can say your input, right? Like, so if someone comes and says, what are your thoughts about immunotherapy? My first one is you should go talk to a medical oncologist. But at the same point too, I'm like, I've seen some successes. I've seen, areas where it maybe it's not the best option. And you can say like, you can have this go have a discussion with them. But then you can also still say your opinion. Like, I still think like you should, in my space, get a local regional therapy on top of it, or you guys vice versa. So I think more information is always better. And then, half the clinic visits, you're telling them, don't believe everything you read on the internet, right?
There's another, sorry, go ahead.
Facebook groups aren't everything.
Truth. So, there's another side of this, which is, and it's not super common, but it happens. I work in New York City. Mm-hmm. There's a lot of hospitals. And every so often, there are patients who just, I tell patients, if you want a second opinion, this is your right information. But there comes a point where if you're getting, what I tell patients is, listen, you can choose wherever you want to go for care, but choose one institution, right? Because the relationships we have amongst each other, you're not going to get the same care, honestly, if you're getting, your IR treatment here, but then your surgeon here. And it's communication's harder. And I just really, really believe in that multidisciplinary team. So for patients like that, obviously I see them, I want them to see all of my colleagues together if we're going to treat them. But at the end of the day, I'm like, I'm not going to be offended if you don't get care at Sinai, but just for your health, you should just really stick to one place.
I think having a unified front is obviously helpful, and that is easiest if you're dealing with the same team at one institution. But as much as shared decision-making is important, I think for patients like this, sometimes this concept of what's been described to me before as palliative paternalism is helpful. Like, you just need to tell the patient, this is what I think is best for you. And sometimes it's an ambiguous, gray zone like we're talking about. But if it's a clear-cut answer, the patient needs a clear-cut recommendation on this is what 99% of oncologists throughout the country would recommend for you.
And the other side of the picture is, what if the doctors have a different opinion? Maybe a surgeon doesn't like to have Y90 before a resection or whatnot. How do you navigate that, problem?
That's all at tumor board, right? That's where you have everybody together and making a shared decision from that perspective, right? Obviously, I'm not a surgeon. So if the surgeon said, I can't do surgery if you do something, I'm not going to tell them like, yeah, you can. Go do it, right? I can't. But that you can have a discussion at tumor board with every different specialty there and come to as best of a consensus or, majority decision as you can.
Yeah. Do you find that at all at Sinai?
There are instances where should we do this first versus that? And it's a discussion. But I think for the most part, fortunately, we're all pretty much in agreement. I do recognize that's probably not the same everywhere. But when it comes to my conversation with the patient, so with my time with the patient, I always, information, obviously giving them information about what I can offer, my knowledge, also noting my limitations, right? So if you really want to discuss immunotherapy, you really should. I am not the right person for this information. I can tell you what I know, but you really should talk to this person. So I think informing the patient about all their options, and even if it's okay to say, I don't really know the answer to this, but I know the person that you need to talk to. And they're always very reassured when you talk to them and you're like, listen, I'm going to discuss your case tomorrow with a group of experts, or this is what we discussed in tumor board. So, and fortunately we tend to reach consensus.
Yeah, I mean, again, it's so variable everywhere. And, I just try to come up with some complex scenarios. Do you guys have any complex scenarios that you've kind of recently encountered?
I have one for the medical oncologists, because this comes up at our tumor board all the time. If we do a combination therapy, and our intent through the combination therapy is to treat all of the visible disease.
For BCLC B.
Any BCLC. So for whatever reason, they're on systemic therapy and we're doing some sort of combination therapy and we're able to treat all of the visible disease. How do we decide to continue therapy or not continue therapy, or what are the factors that go into that? If we can't see any disease left.
In terms of continuing systemic therapy,
Mm-hmm.
It's an unknown. Many immunotherapy clinical trials in HCC and throughout oncology did have stopping points after 1 or 2 years of immunotherapy for people that had complete responses. Obviously, those studies did not include the exact question that you're asking, whereas if we had a combined modality strategy, we have patients that we do stop therapy on. People probably don't need immunotherapy indefinitely if all of their disease has been treated. But it's an area that we don't know the answer to the question. We have to kind of use our best clinical judgment.
I think the CheckMate 9DW trial, they used ipi/nivo for 2 years. I believe the Himalaya and the I'm Brave 150 trial use indefinite systemic therapy. I think in our experience, I personally just have continued to treat the patients. Of course, not that many patients will live like 5 or 6 years beyond, right? Those are really the minority of patients. But there are definitely patients that say we treat with Y90 and systemic therapy after 2 or 3 years that it has been NED for a very long time. Then a lot of times patients will like to have a treatment break. And I feel that's definitely very reasonable. We just give them a break and see them every 3 months with surveillance scan. With HCC patients, I do feel that they're a different patient population because they still have the cirrhotic liver. A lot of times, eventually, they develop a new HCC.
In how long of an interval have you seen that?
It depends. I have patients like they're actually on systemic therapy and we Y90, we treat everything. And then 6 months later, they have another like small HCC that we like just zap it with Y90 again. I also have patients like maybe 1 or 2 years out, they have like recurrent HCC.
How about those patients where you do a treatment, a liver-directed therapy, and then the next treatment scan, there's an explosion of tumor?
After combination?
After combination or single LDT?
Single LDT, like if that happens, say after Y90, exactly, we just throw systemic on them. But for a lot of patients, we start with combination and then it's tumor biology is king, right? They just blossom through. It's really bad prognosis. We have other treatment, like we can give them lenvatinib, cabozantinib, whatever the TKIs, but it's really bad biology that they don't usually do well.
Any other complex scenarios?
No, I had another question for the love having the medical oncologist on site, or, for both of you as well. So, there's all this hot topic, right? Immunotherapy, local regional, and there's a lot of happening in the clinical trial space. Any thoughts on what the data is going to show, or?
It's a hot topic, as you mentioned. I think the existing data that we have, including the most recent for TACE plus either immunotherapy with Bev or immunotherapy with lenvatinib, is early. We see a PFS benefit. It's not a screaming benefit. We don't know that it's going to translate into an OS benefit. And then, as we all know in the US, how that translates into our population that we don't really use that much TACE, it's hard to just extrapolate data or think of a patient that would be helpful for. So, I'll speak for Zach. I think we're probably most excited about combinatorial approaches using TARIN immunotherapy. Those studies are not as advanced and ongoing now, so I think we're excited to see what those endpoints are. One concern I have is you guys are so good at your jobs now that the response rate to TARA is so high. What is immunotherapy going to add on top of that? I think that is the main research question of these studies, but it's going to take some time to sort that out because we're seeing such high response rates.
That is actually a very interesting topic, now that you bring it up. I do feel that with Y90, the most important advantage is the response rate is very high, right? Our systemic therapy nothing can reach that have a response rate. But the benefit with systemic immunotherapy is a lot of times if people have a response, some of them have a very long survival tail, like they are the long-term survivors. So that is why Ochsner, for a lot of like selected patients, we actually combine both. Our thought behind it was like, if we can get a good response in the beginning, hopefully that can, like, they respond better to immunotherapy and eventually become the long-lasting tail that they can survive for years. We're still like gathering all the data. Like, we have good experience with that, but still we don't have it published yet. We're still getting our data. But I think even with the Himalaya study, when they reported the 5-year over survival, they did feel that the long-term survivors, the majority of them were those who had, say, either a partial response or complete response in the beginning. That's really the majority of patients who are surviving for 5 years. So, of course, that's only responding to immunotherapy, right? So you're cherry picking the best biology patients. But that's my question. Like, if we induce more response, would they have a better chance of surviving longer?
And then the order of therapy you're talking about is a good response to Y90 and then starting systemic, or this is starting systemic initially?
So in our retrospective experience, it's like we did the study, it doesn't matter. Like regardless whether you start Y90 and then immunotherapy or the other way around, doesn't matter. Yeah,
there's so many options to treat these patients. Again, when you go to this gray zone, I mean, this is kind of why we're having this discussion. And I get all these gray zone patients, and I frequently call like my mentors and things for advice. What kind of resources do you guys have for people out in the community who need questions?
So at least on the interventional side, it's such a small specialty. You know, almost everybody knows somebody in the space who does a high volume of this. So definitely reach out to them. But I think the whole world needs to understand that we're also all just trying to figure this out ourselves, right? We don't have dogma. And so, you know, the question I always get asked, do you do Y90 first or do you do immunotherapy first? And the answer is we don't know, but also there's no right answer. For some patients, it would be one versus the other, and another patient would be another one versus another one. And so I don't think anyone can definitively answer all of these questions.
Right. And the world is rapidly evolving as well. We're all part of it and rapidly like just being wrapped in the rapids.
With all these new technologies coming out and everything, it's great. So, you know, this is a big topic, but, you know, I think we're all learning, just like you said, we're all learning and evolving. And I think with other modalities, histotripsy that's coming up, we're going to be learning a lot more. So thanks. I'd like to thank all of you for being part of it. And I look forward to talking to you guys more, learning more.
Thank you.
Thank you.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.